And we've started recording. Jody, you're on.
Hi, my name is Jody. I'm one of the nurse practitioners at St. Luke's in Milwaukee, Wisconsin in the Cardio-Oncology program. And I'm here with Sarah.
Oh, hi. My name is Sarah Zakor-Zorn. I'm the pharmacist here at St. Luke's for Cardio-Oncology and Cardiology.
Great, Sarah.
And I'm Becky. I'm the nurse for the Cardio-Oncology program here at St. Luke's in Milwaukee.
And then we have Dr. Tohan on the phone as well, our program director.
Welcome.
We wanted to present the case, 67-year-old female with multiple myeloma. She had other medical history of mild coronary artery disease back in 2001, had just minimal coronary disease on a left heart cath. Also had carcinoid tumor of the stomach in 2011, status post-resection, had pneumonia with sepsis in 2009. At that point had a left heart cath as well, which showed mild coronary artery disease. She had that because during that admission, her heart function had reduced with an EF of 39%. Also paroxysmal atrial fibrillation in 2011 after her stem cell transplant. And then type 2 diabetes, which was diagnosed at age 30, hypertension, peripheral vascular disease, chronic kidney disease, osteoarthritis, myasthenia gravis, and reflux disease. Family history, had diabetes. She also had significant heart disease in her family with a brother with coronary disease at age 32. And interestingly enough, a sister who had coronary artery disease, CABG in her 40s, and now recently has developed cardiomyopathy as well as breast cancer. And this was found kind of on her baseline echo for breast cancer treatment. The patient didn't know any more about this, but it's something that we'll explore further. So in 2011, she was initially diagnosed with multiple myeloma and underwent induction therapy with high-dose chemotherapy and stem cell transplant at Mayo Clinic. This included lenalidomide, melphalan, and zoledronic acid. And then she was maintained on treatment with lenalidomide. In 2016, she had relapse of her multiple myeloma and was started on the Castor regimen. With Daratumumab, Bortezomib, and dexamethasone for 16 cycles. During that time frame, she had some drops in ejection fraction to as low as 30% with a GLS of -10 and had some heart failure symptoms. Also had an episode of chest pain and blood pressure was a little bit elevated at 131/67. And this was on metoprolol. So with this drop, she had been seeing a cardiologist within the system who started her on this beta blocker and was kind of up-titrating goal-directed therapy. They continued the Daratumumab until this EF got down to 30%, and then she was referred to the Cardio-Oncology clinic. When she came here, looking at her medical history, we looked at the risk factors she would have for cardiotoxicity. And that was she was female, she was over age 65, she had hypertension, diabetes, family history of early cardiac disease, and then her own atrial fibrillation history and this mild CAD that she had. This was her EKG. So she had these nonspecific T-wave abnormalities. So this just kind of summarizes what had happened in a timeline. 2011, she had her chemo and her stem cell transplant. And with that AFib and hypertension in 2012, she had been on metoprolol aspirin, had her relapse, started the Daratumumab, Bortezomib, dexamethasone, and then had the EF drop, and chemo was held in April of 2017. So she came to our clinic. And questions, what would you do in this situation? Thoughts? Would you continue chemotherapy with no further evaluation, delay chemotherapy for medication optimization, reassess heart function and symptoms, do a non-invasive evaluation with MRI and non-ischemic studies, or diagnostic heart cath?
So Ron, would you like to address that?
Sorry, what are you saying? missed that. I mean, basically, you have to be concerned she's got amyloid going on, among other things. And so I'd be inclined to make a diagnosis before proceeding. An MRI would be something that would be helpful for the LV function. And also, I think her medications could be better optimized. I mean, he has her on metoprolol, which is not really the best of beta blockers. And you'd want to see that change to carvedilol if she tolerates it, among other things. And I think making a diagnosis would be important.
So, Ron, can I ask you, this is Vinay Cohen, can I ask you, would you go directly to a biopsy? Would you do some peripheral biomarkers? Would you do some other things that might clue you in?
Well, that's a difficult question. I mean, I think biopsies are being advocated now more aggressively than they certainly used to be, and as people get more comfortable with them. So I think that, in my opinion, it'd be sort of optional to go right to a biopsy or get an MRI first, and just perhaps get a better idea what is, how much of a myocardial fibrosis and whatnot is going on. But I think a biopsy is very close to being done. I don't know how you.
Would you think? Do you think echo with strain helps you at all in this scenario?
Oh, I forgot. She didn't have an echo.
Yeah, she had an echo. Yeah, she had an echo with strain. And do you think the pattern on the strain might help you, make a decision earlier or later?
Well, we've been using that a lot for the diagnosis of amyloid, with sparing of the apex. And so that really is sort of the first screening we've done for, looking for an amyloid or something other than a global cardiomyopathy. So certainly strain is that's sort of a given in a way. That's really cheap and easy. And then at that point, you'd have to see if it looked really like amyloid, you may want to go right to a biopsy.
Well, because of her history of diabetes, her family history of coronary disease, we did repeat a left heart cath, which really showed the same as what they had previously. And we did a cardiac MRI, which really did not think or point to amyloid with this. Mm-hmm. And then the rest of her non-ischemic diagnostic labs were negative.
Yeah, I think that biopsies have a risk. There's no question. You always say there isn't a risk, but there's a risk. You see damage to the tricuspid valve. Occasionally you see a little chordae pulled out with tricuspid regurgitation afterwards. Even part of a leaflet occasionally has happened, even under the best and most experienced operators. So I think although biopsy is extremely useful, you have to be able to say to yourself, yeah, this was really indicated if there is a complication. And I think that's the important part of making that decision.
That's the approach we use. We often, we have an excellent MRI facility, and we often use our MRI as an adjudicator for the need to do a biopsy or not. And, yes, if the clinical suspicion is so high that, and the risk of MRI, although the risks of MRI are pretty low, and in most patients, especially if you're looking for amyloid, you don't have to give gadolinium in order to look for amyloid per se. Now, other infiltrative heart diseases or other forms of cardiomyopathy, gadolinium certainly helps, but you don't have to give gadolinium. So even in patients who have advanced kidney disease, which this lady did not, you could use MRI as sort of your decision tool. I'd be interested in hearing what the other folks say about their use of MRI as opposed to either biopsy or echo.
Let's see, I thought she did have some kidney disease. What was her status on kidney disease?
So she had a history of chronic kidney disease stage 3. As we've seen her here, her GFR has been normal.
So she did get gadolinium?
Yeah, she got gadolinium as part of this. And,
yeah, did
the GFR? Yeah, I think the GFR cutoff for that is 36, and her GFR was above 36.
And did they scan early? Because sometimes we miss the amyloid if you scan too late. If you use the standard protocol, you miss amyloid.
So the way that we do it is that they look to see if whether the myocardium can null, and they look at they'll look at the time to null or if it can null, And if it's greater than like 1100, then most of the time, I mean, that's going to be pretty sensitive for amyloid.
Okay, so we feel pretty sure she didn't have amyloid then.
Oh. So Sarah's going to talk a little bit about the mechanism of actions of the different drugs that she received that could cause potential cardiac involvement.
Yeah, so once we had ruled out amyloid and other causes, and the MRI suggested that there would be either, that it's possible that she experienced cardiotoxicity, we looked into her chemotherapy drugs. So like Jody said, she got Bortezomib and Daratumumab. Bortezomib, I think everybody is more familiar with, also known as Velcade. It's the first proteasomal inhibitor that has been out on the market. It reversibly inhibits 26S, which is responsible for degradation of intracellular proteins via the ubiquitin proteasome system. And this ultimately leads to cell cycle disruption and induces apoptosis and active cell death, which is how it's used for multiple myeloma. On the package insert, there is a warning for worsening of and development of cardiac failure, and to closely monitor patients with existing heart disease or risk factors for heart disease. Now, when looking at the actual evidence, there hasn't been too many reports. There's been some case reports. There was an APEX trial, which was one of the biggest trials that they actually looked at Bortezomib versus dexamethasone, and the incidence of cardiac disorders between the two drugs was 15% versus 13%. And 2% in each arm developed heart failure. So really, there was no difference in heart failure between the two arms, and a slightly increased risk of cardiac disease in the Bortezomib arm. Meta-analysis was done looking at about over 5,000 patients that had received Bortezomib, and they saw a 3.8% incidence of cardiotoxicity. They actually concluded that patients receiving Bortezomib did not significantly increase risk of cardiotoxicity compared with the control. However, there probably is a slight increase, and it also might be due to patient risk factors with multiple myeloma as well. So we also looked at Daratumumab, which is a brand, more of a newer drug, also known as Darzalex. It's the first approved drug to inhibit CD38, and it's indicated for refractory or relapsing myeloma. It was only studied as a monotherapy, not in combination with other chemotherapy agents. So being the first agent to inhibit CD38, how does this actually translate into humans? Well, if you look at this chart here, it shows its mechanism of action. So it's a human IgG1K monoclonal antibody. It binds to the CD38 epitope and induces target cell killing of the myeloid cells. It was approved in November of 2015, and it was approved under orphan drug designation. So in the United States, that means that it had a FDA accelerated approval, which is with a lot of the newer chemotherapy drugs. So 2 open label studies were done with 149 patients. They did not know any cardiac side effects, just infusion-related side effects. And then 1 randomized phase 3 trial was done with about 500 patients, and they found ischemic stroke in 2 patients, but no notes of heart failure or any other sort of cardiac disease. Now, there still is ongoing studies with this drug, so once those are released, we'll see if there's anything else that has been reported. Now, going into a little bit of CD38, since it is a new mechanism of action, why have they really looked into this, and why are they using it for drug development? So CD38 hydrolyzes NAD to NADP and CDAP, and this regulates intracellular NAD and nicotinamide levels. In turn, it regulates intracellular calcium. Now, these secondary messengers participate in several physiological processes, from insulin secretion to hormonal signaling, and to, more importantly for this case, cell death and apoptosis. Also, immune response and smooth muscle contraction. So are there any cardiac implications with this? Well, we do know that alterations in NAD concentrations and the NAD-NADH ratio have been involved in mechanisms that have led to heart failure, most importantly, the impact of calcium signaling in the mitochondria. There was a mouse model that was done where they induced deletion of the complex 1 subunit of the mitochondrial electron transport chain, and this decreased the NAD-NADH pH ratio in the mitochondrial matrix. When they treated these same mice with nicotinamide, which is a precursor of NAD, they restored normal mitochondrial permeability and transition pore sensibility, and then deacetylation of mitochondrial protein. So basically saying that these patients who they restored NAD function had more normal results. An alternative study indicated that CD38 deficiency in mice actually protected the heart through activation of a antioxidative stress pathway. So we really have two conflicting mechanisms there. So we don't fully understand the impact of CD38 inhibition in the heart muscle tissue. So we do know that it plays a role in physiological processes of cardiac muscle, including calcium signaling. There is some evidence that it indicates that cardiomyopathy can occur with inhibition, while cardioprotective mechanisms have been described as well. There really needs to be further studies to fully understand the role of CD38 inhibition in humans. It has been studied for several years in mouse models and cell models, however, not in humans. Clinical effect is likely based on individual baseline characteristics, including cardiac risk factors and genetic predisposition. So in normal patients, there might not be an effect on the cardiac tissue. However, if calcium homeostasis is already deregulated, then it could possibly worsen that. Now, the combination with Daratumumab and Bortezomib has also not been studied, so it could be that there is a synergistic effect with cardiotoxicity as well.
Questions or comments about any of that?
Are there any interactions with calcium blockers with the Daratumumab?
None that are known. But again, it hasn't been studied.
Sure.
Yeah, so it's possible that.
I think this is one of those scenarios where, again, an orphan drug hasn't been tested in multiple combinations with chemotherapeutic agents, and then you see something. It's very difficult to tease out exactly whether it's related to the drug or not the drug, and whether therapeutic interventions improve things or not. But when we sort of delved into this a little bit, we felt it was reasonable to take a pause from the Daratumumab and maybe optimize medical therapy for this lady. Discussed that with our oncology colleagues, and they were willing to at least pause, maybe not completely discontinue, but pause the therapy for that. And maybe Jody can fill us in on what happened.
All right, so this kind of talks about shows when the patient came to us what we did. So we did that testing to really evaluate this drop in ejection fraction and heart function to look for amyloid given her multiple myeloma, and that really came up negative. So we looked towards the drug as a potential, and we held the Daratumumab. We talked with oncology, and they felt it was reasonable to try and hold that, and got her optimized on medications. We started spironolactone, carvedilol, lisinopril, which she tolerated well, and we up-titrated quickly. And then her ejection fraction actually did improve with those agents and with holding medications. And then in October, she was restarted on Daratumumab and pomalidomide, and then had some palliative radiation as well. These are just her echoes. This was her echo when she came to us with that reduced ejection fraction, and this is post holding her agents and getting her started on goal-directed therapy. And then this is a follow-up echo that we did. And you can see the GLS here. She doesn't have that classic apex sparing on this GLS as well.
So I noticed you used lisinopril instead of Entresto. Can you tell me about the rationale?
So
I have no rationale.
Lisinopril, not Entresto, to see if she tolerated it. Her blood pressure could have tolerated it. Her kidney function has been good here, but really wanting to get the rest of those drugs and not starting Entresto right away. And then looking at potential drug interactions with chemotherapies and then the cost to the patient. She's a patient who's going through a lot of healthcare costs, but then her copays are fairly elevated.
Yeah, no, those are that's actually a really interesting conversation. I think still there's no real indication to a priori start Entresto. We don't have any data that supports that. It's usually, chronic heart failure that have been on ACE or ARB first. So I think in this setting, and then of course when you factor in the cost, et cetera, that you just mentioned, that lisinopril was an excellent choice, obviously.
There we go. So this is a chart just kind of showing the EFs that were obtained even prior to coming to us. So this is when she came to us here, and then this is the improvement with therapies, and then resumption of the Daratumumab and pomalidomide here in October. And with that resumption, her ejection fractions have remained stable, but she continued to have some progression of disease, and would switch then to carfilzomib based on Mayo Clinic recommendations. She kind of travels between here and Florida and has multiple players in her healthcare. So this was started, carfilzomib, in February, and her EF has remained stable on that. So we will continue to follow her with echoes, continue her on goal-directed therapy. She's actually doing well from a cardiac standpoint with minimal symptoms. And our plan is to do echoes we'll do another one in 3 months just to assess stability, but I'll see her in a month just to look at symptoms, make sure she's not developing heart failure symptoms. Would anyone do anything different for this lady at this time?
No, I think, this is an excellent description and story. I think the biggest thing with combination therapy with myeloma is more about thrombosis. So I think that she needs to be on, absolutely at least aspirin, but you could argue that she should be on some sort of other anticoagulation. And I haven't really felt that I've ever seen a case of LV dysfunction that I would attribute specifically to Daratumumab. I think that in this setting, it's unclear because she had the, sepsis in the past, and she has, myeloma, so she has a lot of prior treatments. So I think there have been a lot of insults in her past. And then, once you put her on appropriate heart failure therapy, her EF, improved. So, I don't know. It's a complex story, but I will say that anticoagulation is probably the biggest single issue when you have patients on proteasome inhibitors or Daratumumab plus an IMiD, and they're getting active treatment for their myeloma.
What do you think about the role of troponin in this situation? I mean, in some ways, I like to get a troponin. If you see an elevated troponin, you say, well, there's some active injury going on at this point, whereas if it's normal or low, then I don't feel you have to follow them as closely. And certainly with these changes in therapy, if the troponin did go up, this would sort of alert you to a, impending problem. I don't know, the data on this is obviously controversial at the moment, but I just wonder how people are dealing with that.
Yeah, I think we did a study that we reported on in March at the ACC called the PROTECT study. And we did serial BNP or NT-proBNP plus troponin on patients that were undergoing, myeloma patients that were undergoing some proteasome inhibitor-based therapy. And EF was not particularly helpful at all. The troponin was really not helpful at all, but the natriuretic peptides were extremely helpful in terms of identifying people that were either have developed or were going to develop a cardiac event.
Thanks.
So Dan, which troponin did you use?
It was, this was when I was at Vanderbilt, so it was the troponin I that the institution did, which I think was what's the one that begins with an A? Allegre or something something. What is it? I forgot.
Yeah,
Anyway, a standard troponin I assay that was considered high sensitivity, but not ultra high sensitivity. So there may be a different assay that's better. So that's what was done.
Yeah, we've started using the troponin T 5th generation Roche Cobus platform, which is the ultra sensitive of all ultra sensitives at this time, available in the United States, approved in April of last year. And so we're just starting to get that in use, which has a 30% false positive in the ER. Well, not really false positive. It's a 30% positive. It's positive for LVH. It's positive for myocardial infarction type 2. It's positive for a lot of things. And so, but it should be interesting to try and see what happens with these patients, and be interesting to talk to Dr. Cardinale about that as well.
Yeah, I think that there obviously are different troponin assays and different levels of sensitivity, and then depending on what institution you're at, whatever the institutional lab decision has been made as to which company they're going to go with. So I think there's a lot of differences there. I do think that in our prospective study in which we defined these things, the one thing that was very clear is that the natriuretic peptides were useful. So, I mean, I think troponin is particularly useful in a patient with myeloma that you're starting to worry that they may be developing amyloidosis. So, I'm a fan of troponin in general. I just don't think it did not pan out to be particularly useful in these patients.
It seems to me, though, that troponin is probably a later process in the cascade of cardiac injury. First, you have elevations in filling pressures, which probably why the BMP biomarker actually works a little bit better, maybe a little more sensitive, not necessarily as specific for cardiac injury. And then, obviously, troponin later in the process, once you have injury, you manifest a leak in troponin. So, it seems physiologic.
Yeah, and I think that, just like, your case, this is a beautiful case in terms of, it really just shows, you have LV dysfunction during the course of cancer treatment, and there's potentially 15 or 20 different explanations, and I think classically we've always attributed it specifically to the chemotherapy, whatever that was. And I think it's kind of uninformed, because I think there are many possible explanations.
So we have another case of fluoropyrimidines. I think we have time. Oh, yeah.
Yeah, I think we do.
So this is a 68-year-old male with rectal cancer who was diagnosed in May of 2017, had chemoradiation with capecitabine, and then presented to the ER a few days after that with chest pain. His history, he did have cardiac disease with a stent to his RCA in 1997, and then repeat stenting in 2009, hypertension, hyperlipidemia, as well as atrial fibrillation. And he had no anticoagulation because of rectal bleeding. He had smoked but quit in 1997. He also had morbid obesity, family history of stroke, and coronary disease. Medications, metoprolol, 100 milligrams, metoprolol, atorvastatin, aspirin, and Quinipro. This was his EKG from the ER. I think that's pretty impressive. So that bought him a trip to the cath lab. And during that cath, it showed a stable 60% lesion in the RCA, and really thought to be coronary vasospasm that caused all of these symptoms and EKG changes. So while he was in the hospital, his metoprolol was discontinued. He was started on diltiazem and isosorbide, and he had some sublingual nitroglycerin PRN, and his symptoms subsided. So After this episode, he was referred to our clinic for evaluation as far as could we re-challenge with fluoropyrimidines. I'll have Sarah talk a little bit about the mechanism of action.
Yeah, so when this patient presented to us, we kind of went through all the mechanisms of actions with the fluoropyrimidines and vasospasm. So the fluoropyrimidines consist of oral capecitabine and then IV 5-FU. 5-FU converts to two active metabolites, FDUMP and FUTP, and then this inhibits the metabolite formation, which then therefore inhibits cell division and DNA synthesis. Also, FUTP can interfere with RNA processing and protein synthesis. Capecitabine is the oral form of 5-FU. It's a prodrug of 5-FU and converts to 5-FU in vivo. So cardiotoxicity with fluoropyrimidines has been reported. There's a wide variation of reports from arrhythmias to heart failure to vasospasm. Silent cardiosquemia is another report. Most commonly is anginal chest pain, up to 18% has been reported. Usually this develops within 2 to 5 days after 5-FU administration. The median duration to first occurrence with capecitabine is 4 days, but it can range anywhere from 2 to 15 days. So if you think of it converting to the active drug in the body, this would make sense with why you would see a more delayed reaction than with the IV. Cardiotoxicity is usually a diagnosis of exclusion, so they really do need a whole cardiac workup. And active coronary spasm is not always present on angiography, so we were lucky to see it with this patient. However, you're not always able to diagnose it then. For withdrawal of chemotherapy may result in symptom relief. With the infusion, it can be within hours, but it can actually take up to several days to resolve because of the pharmacokinetics of the drug. The proposed mechanisms of cardiotoxicity, there's several theories. So one is that endothelium-independent vasoconstriction through protein kinase C can directly cause vasospasm. It's also been thought that there's direct cellular toxicity of the drug, and this can cause microthrombotic occlusions that are undetectable by angiography. Also, possibly free oxygen radicals might have a role in this as well. The metabolite of 5-FU degradation might also be directly toxic to the cardiomyocytes. And then the drug itself might diminish the ability of the red blood cells to transfer oxygen as well, therefore causing vasospasms. Some risk factors have been proposed. However, it's not well described or well known, but ischemic heart disease is a possible risk factor. Renal dysfunction due to the accumulation of the metabolites. If you use cisplatin in combination with 5-FU, although that mechanism is not fully understood. Leucovorin in combination with continuous 5-FU infusion, and then between continuous 5-FU infusion and the bolus infusion, there's some thoughts that the continuous infusion might have a higher risk than bolus. However, there is no data on that. For management of cardiotoxicity, there's proposed strategies for oncological risk. You can reduce the chemotherapy dose. You can try continuous versus bolus infusion if the patient was on continuous, maybe transitioning to bolus or vice versa. For vasospasm management, there's conflicting data. However, there's been proposed mechanisms to try and prophylax with calcium channel blockers, long-acting nitrates, or beta blockers. And there's very little evidence on those drugs and prophylaxis of vasospasm. With the fluoropyrimidines, this is the evidence that's out there. So in 1990, there was a study that looked at 58 patients in prophylaxis with verapamil for patients with esophageal or head and neck cancer that were receiving cisplatin with continuous 5-FU infusion. And they found that the signs of ischemia or ST changes were only 12% with the intervention group versus 13% in a comparable group that didn't receive the intervention. The American Journal of Cardiology had a report of 5 patients with colorectal or anal carcinoma who experienced chest pain with ACS rule-out, and they were on capecitabine and started on diltiazem prior to retreatment. And they found that 1 patient had less frequent and milder episodes of chest pain, and 4 patients had no further chest pain. So could possibly work for re-challenge in those patients. And then there was a case report in 2011. A patient experienced chest pain and EKG abnormalities with 5-FU with a negative CAF, did have an EF of 15%. They stopped the chemotherapy and then started diltiazem and ramipril, and they found that the patient had a second cycle with half dose of 5-FU, and then with the third cycle, the patient did have cardiac arrest at that point, and the therapy was stopped, and the patient was asymptomatic 4 months later. Now, this may also be due to the low EF, and this was just a case report. So, but this is really the evidence that is out there. So for this patient, like Jody said, Cardio-Oncology was consulted after the patient was discharged, and we recommended that he was high risk for continuation of capecitabine therapy, and if the chemotherapy was deemed life-saving, then possibly doing 5-FU with nitroglycerin infusion in cardiac observation. However, the patient did opt to discontinue capecitabine. He no longer wanted to experience any vasospastic events and decided to just do radiation and surgical resection. So with that being said, does anyone have any thoughts on this case? We do have a scenario that we'd like to present to you also for your thoughts.
Yeah. Can you guys hear me?
Yeah.
Yeah?
Yes.
Oh, great. Okay, so we actually reported 11 cases in the Journal of Gastrointestinal Oncology last December of successful re-challenge. We probably have 5 or 6 more people since then, and it's totally safe even with people with documented spasm, underlying coronary disease. It's one of the best things that cardio-oncology can do. So we use a combination of indoor diltiazem and nifedipine. We have a protocol. We never ever continue with Folfox, with continuous 5-FU, because you can't stop spasm no matter what you do with continuous infusion. We're 100, and we usually get, well, we always get the oncologist to switch to Flox, which is just a bolus injection of 5-FU. It's not as convenient because they have to do it weekly for a number of weeks and then get a week off. But we've been able to successfully retreat everybody. And capecitabine really behaves exactly like the continuous infusion, so that we've only been successful 2/3 of the time in making it happen. But re-challenging with a lower dose, using beta blockers actually doesn't make any sense from the standpoint of the mechanism of spasm, and that we I'm happy to share the reference with everybody to see our protocol.
Yeah, Joe, I just sent that to Eric and you, so maybe if Eric can send that out to everybody, that would be great. But I would, I think this is an excellent practice report. I think that's really important because, this is you've used your experience to try to navigate through the sort of complex picture that you got here. The only things that I would kind of add to this picture is that in terms of vasospasm, if you just focused in on vasospasm itself, whether you thought it was due to 5-FU or whatever other causes of vasospasm may exist, there are a couple of really important points. Number one, you have to optimally treat for vascular disease. So they need aspirin and statin for sure. And if they weren't on, effective drugs for endothelial dysfunction, then then you need to do that. Now, I'm not inclined to use diltiazem for a variety of reasons, but in terms of a vasodilator that would be effective in terms of preventing vasospasm, I'm sure that it has its role. I would usually use Norvasc or even nifedipine in this case, because the situation like when you have Raynaud's, where you have a vasospastic type response, Norvasc or nifedipine are particularly effective at attenuating the vascular hyperresponsivity that is happening. And then, of course, nitrates are critically important. But actually, this is in the previous millennium. So when I was a fellow, I had a couple of cases where patients with alcohol exposure had profound vasospasm. So, and this could be even something, one of the cases, it was this patient that she just had an extreme sensitivity to alcohol, and she got it in cough syrup. She wasn't drinking any alcohol, but she was taking cough syrup, and then every time she had a cold and took cough syrup that had alcohol in it, she'd get vasospasm. It was really kind of a bizarre case.
Yeah,
but I would
have to comment. Sorry.
Yeah,
that is a illness worse than death.
That's right.
Yeah. So I have to comment though. For me, diltiazem is really my go-to drug. I had diltiazem on the IND when it first came out, and there was one patient who was dramatic, was treated with nifedipine, which was also had by one of our other doctors, and this lady came to me on her way to surgery. We gave her diltiazem with the first dose. She was cured, basically. And, spasm is very common in Japan. I had a conversation with a Jap, and I've had really good experiences. People on their way to surgery, we put them on diltiazem before Renexa was available, and they've done extremely well. And I talked to a Japanese physician because, as you know, spasm is very common in Japan. And I asked him about the relative back and forth, and there was some early comparison between, on very small numbers, and when these drugs first came out. And he said that diltiazem is their absolute better drug. That's the drug that they actually use, and of course it is a Japanese drug. And the other point, which I think, Joe, you mentioned also, was the fact with beta blockers. We actually had a patient that we reported on where spasm was caused by just a standard beta blocker. I think at that time it may have been propranolol for all I know, but basically beta blockers are the absolute wrong drug to give. But really, I would agree. I've had very good results with diltiazem and nitrates. And the other point I wanted to make, which is sort of unrelated to this, but I just wanted to bring it out. I saw a patient who was being treated with Folfox for pancreatic cancer, and 2 weeks after her infusion, she had a bad day of being nauseated and throwing up and felt weak and never felt good. The next time she saw her doctor, she had Q waves everywhere, and her ejection fraction was 10%, and she never was cast, but she had a myocardial perfusion scan that was very clearly ischemic and infarction. And so this was a very unusual case. I've never heard of one. It was 2 weeks after stopping therapy. She apparently had what sounds like an infarction at home and survived it. And obviously the question was, can you resume therapy? And that was a joke. We couldn't do it, obviously.
I've a couple of other things. First is, this was a great case presentation, so I thank you. I think that one of the things that I've recognized over time is that we oftentimes don't do, or oncologists don't do a good enough job when they start 5-FU or capecitabine in telling people about chest discomfort and to immediately report it. And I would say that most of the patients that I've seen come after 2 or 3 cycles of having chest pain during the infusion, which they either ignored or didn't tell anybody about. And it's really important to do patient education up front.
That's a really good point.
Thank you, everyone, for weighing in. I think these are more and more of the patients that we're seeing with the fluoropyrimidines and really knowing what to do with them. think is important, and I'm hoping there's more and more research. So I think it's nice to hear that that you have developed a protocol and seen positive results with being able to re-challenge.
Yeah, I think it's this is a great case, and I think that it's really fantastic to bring up the issues.
Very nicely done.
We had a third case, but I think we've discussed everything. We just had another female 51-year-old with metastatic colon cancer who needs re-challenge with 5-FU, but I think we've already discussed all of the potential options.
Thank you so much for a great presentation of two great cases that brought a lot of salient points up. Thank you so much for everybody's contributions. We had a great conference. We're looking forward to everyone arriving in Tampa on the 27th of September. And so for the GCOS meeting. So thank you for your attendance, and I'll see you next month. We will be posting this on Vimeo, and you can probably go to Eric E. Harrison, MD, Vimeo, Vimeo, and be able to find it later today. Okay? Thank you so much.
And then,
Bye-bye.
Eric, if you don't mind, if you could forward out Dr. Carver's article, that would be wonderful.
Thank you, Dan. I've already shot out a couple copies, and I'll shoot the rest of them out.
All right. Thank you.
Bye-bye.
Thanks, everyone.
Bye, everybody.
Bye.
Thank you. Bye.
Bye-bye. We'll end this meeting. End webinar.